Bismillahirrahmanirrahim. In the name of Allah, the most beneficent and the most merciful. Welcome to Global Village Oncology Network Sport Specific session. Today, we will be discussing the management of cervical cancers. And our speakers for today's session are Dr. Muhammad Afzal. He's an AKU alumnus and consultant medical oncologist, currently practicing at South City Hospital. We also have with us Dr. Anam Riaz, who is a fellow Gynae-Oncology surgeon, currently practicing at AKUH, and she's an active participant and moderator of our gynae tumor boards as well. Next, we have Dr. Sarish Abrar. She's a consultant radiation oncologist at Khan University Hospital. Her interests lie in treating breast cancer and gynecological cancers, along with her expertise in brachytherapy too. So we'll be starting with our today's topic. We have no conflicts of interest. Our learning objectives include discussing the risk factors and the preventive measures of cervical cancer, along with elaboration on different surgical techniques and incorporation of chemoradiation therapy, and some recent updates in cervical cancer. So to start off, we have a case here, which is a case of 42 years old female with a history of postcoital bleeding and pain for 3 months. Her perspeculum examination showed around 2.5 centimeter ulcerated lesion in the cervix. An ultrasound pelvis showed a uterine fibroid and a hypoechoic lesion in the lower uterine segment. On biopsy, it is confirmed to be a squamous cell carcinoma. So before proceeding to discussion of the management of this case, I would like to invite Dr. Muhammad Afzal to tell us regarding the incidence of cervical cancers first.
Thank you, Mariam, for such a kind introduction. So as we know that the cervical cancer is the fourth most common cancer among the women globally, and roughly it accounts for more than 6 lakh cases new year. So if you look at this map of the world, you can clearly appreciate that the cervical cancer is more common among the areas which belong to the low socioeconomic status, or which have in a low middle income countries like African region, like Southeast Asia, and Latin America. So the cervical cancer is more of a disease of a more low socioeconomic countries, and probably the most common reason for that is the lack of the access to healthcare facilities, lack of HPV vaccination, which we will discuss later, and lack of the cervical screening. And if we look at the mortality of the cervical cancer, that is actually reflecting the incidence on account of cervical cancer. Approximately 342,000 cases of the cervical cancer women died in 2020, and all of these women belong to the countries where the health resources are limited. So basically, it is a disease of developing world or a disease of a low socioeconomic countries. So next slide, please.
I couldn't agree more. Dr. Afzal, you rightly said that in developing countries, the incidence of cervical cancer is really high. And the reason for the incidence of cervical cancer and the risk factors, may I please request you to elaborate further?
Thank you. So the risk factor, the most common risk factor for the cervical cancer is human papillomavirus, which we call is HPV virus. So more than 50 types of HPV strains were there, but it was suggested, or it was stated that 17 or more type of HPV viruses are having the oncogenes which can provoke the cancer. Not only the cervical cancer, but they can also cause the head and neck cancer, vulvar, vaginal cancer, anal cancer. So the top among the risk factors for the cervical cancer is the HPV virus. And how it causes the cancer, I want to explain you in a little detail. So normally what happened that any woman who is above the age of 20, or who are having a sexual contact with a male, in some part of their life, studies have shown that by the age of the 50, they have an HPV infection. And those who are in good immune system, they clear these infections quite well. So any person who had a multiple sexual partner, who had a history of sexual debut at an early age, or who had a low immune system, these HPV virus, these HPV virus basically infect the transitional zone between the ectocervix and endocervix. And when they infect that area, if the immune system is good enough to clear it, they get cleared. But when it was compromised due to certain reasons, like patient is having a history of smoking, birth controlling pills, or for any other reason he or she is taking immunosuppressive therapy, then what happened that these viruses may remain dominant for like 5-10 years, and when they get the chance, they start multiplying, and they produce cervical intraepithelial neoplasia and dysplastic changes, and then transform into the cancer. So the journey from the infection to the cancer is not a 5-10 months or not in a year. It's take 10-15 years from the infection to develop a cancer. And if we go at the molecular level, next slide, please. So these viruses basically have certain genes which we call it oncogenes, which basically inhibit the p53 and retinoblastoma genes, which are basically the guardian genes of the cell cycle. And when these guardian genes become mutated, or when they become dormant, so the cell grow in uncontrollable manner, and that leads to the cancer development. So this is basically a brief pathogenesis of the HPV infection, which is the most common cause of the cervical cancer. And I have already told you that, okay, this is not the only cancer that HPV causes. It can cause cervical, vaginal, and head and neck cancer as well. Apart from the HPV infection, low socioeconomic status per se doesn't cause the cervical cancer, but I think the lack of the healthcare facilities available in low socioeconomic countries, like HPV immunization, screening, and access to the healthcare system, which makes them more prone to develop cervical cancer. And if they have a cervical cancer, it turn out to be late diagnosis and compromised treatment. Apart from that, smoking, oral contraceptive use, multiple sexual partners, they are the risk factors for developing cervical cancer.
So, very rightly said, Dr. Afzal, that screening plays a very important role, and the reason that these cases are more common in the developing countries is because of the lack of adherence to a screening protocol. So, I would request Dr. Anam to tell us regarding the screening protocol or the prevention for cervical cancers.
Assalamu alaikum, and thank you for the kind introduction. And yes, as we are very well aware, and Dr. Afzal has elaborated very well, that cervical cancer is basically the disease of the lower socioeconomic countries and LMIC countries mainly. And it can be prevented, and we have two measures of prevention. It can be prevented either with the help of the primary prevention, that mainly includes our vaccination program, and with the secondary prevention, that mainly includes our screening strategies. So, if we look at this curve, we can see that in the developed countries, what they have done so far is that with the help of the screening, they have reduced their cases and the death rate overall when we see this data from different countries. Next, please. So currently we have three types of vaccinations available worldwide. We have bivalent vaccines, the most commonly known as the Cervarix. We have two other vaccines that are bivalent. One is the Sequelan and one is Valrenvax. They are also available, and these three bivalent vaccines are actually being protective against the HPV 16 and 18 type, which contribute to up to 70% of the cervical cancer alone. We have two types of then quadrivalent vaccines, Gardasil 4, and there is one other vaccine that is known as Cervavax, and they also cover the 6 and 11 type that are responsible for the genital warts. And we only have one nanovalent vaccine, that is Gardasil 9, and it is actually being protective against all these strains of the HPV, that is 6, 11, 16, 18, and the rest of the subtypes. So, how the HPV vaccination should be given, and as we are now well aware that there are a total of 6 vaccines available worldwide. We are usually familiar with only 3 of them, but it is a general protocol that prior to the age of 15 years, 2 shot of vaccination should be given, and after the age of 15 years, 3 doses of vaccination should be given, and the protocol of different vaccines is different. So when we talk about the secondary prevention, we are actually talking about the screening, and screening when it should be started, and what are the different modalities of screening and how it should be incorporated, right? As per American Cancer Society and US Task Force, US Preventive Task Force guidelines on cervical cancer screening, they recommend that a woman, if her age is between 21 to 29, she should get a pap smear, that is cervical cytology, every 3 years. In very simple words, whenever a woman becomes sexually active, she should get her screening done within 3 years of becoming sexually active. And after the age of 30, she could have 3 choices. Either she get a pap smear every 3 yearly, she can opt an HPV test every 5 yearly, or she can have a co-testing. She can have both a pap smear test and an HPV test every 5 yearly. So a woman can opt for any of these strategies, whatever she likes. Next, please. So the question comes that how the screening samples are taken. So what we do, that we have different types of specimen and sample taking instruments, and they are not very discomfort causing. What we do is that we explain the procedure to our patient, and we take an informed consent, and we do tell the patient that what's the importance of taking the smear, and we clean place the patient in the proper positioning and insert a speculum into the vagina. And then we take a cyto brush or an IR spatula. It is inserted into the vagina to collect cells from the cervix. And then we spread it across the slide, or we put it in the liquid-based container that we use at AKUH as well. And then we send it for the sampling. So now we have switched from the conventional pap smear to the liquid-based cytology, because it is more helpful. And with that material, you can also get the HPV typing as well. Next, please. So this graph shows the different barriers to the cervical cancer screening. As we can say what could be the possible barriers when it comes to the patients, that it could either be the cost or the fear of the finding cancer. They could be anxious about getting the procedure done, or there could be anticipation of pain or discomfort. They might not having proper knowledge, and they might have maybe having other problems or transportation. So being the healthcare workers, it is our job how to overcome a lot of these barriers. And now, as per WHO guidelines of the global cervical eradication strategy, they are also recommending the self-collecting HPV sample to overcome some of these barriers. Next, please.
So, Dr. Anam, I would like to ask here something, that when we offer screening to the patients, it's usually pap smear or HPV testing. So, correct me if I'm wrong. Is it like with the cytologic screening is more specific for the squamous cell carcinomas, and for adenos we should prefer HPV testing?
Yes, we could say that. But as we have also saying that now the WHO has recommended that the HPV DNA testing should be the preferred method of screening, because it is more specific as compared to the cytology. And when it comes to cytology, there could be errors in method of transportation, inter-observer errors in learning the smear. But in HPV DNA testing, you can overcome these barriers.
Thank you, Dr. Anam. And one more thing, that considering the ethnic and geographic disparities with respect to the method of screening, can you share how often our population shows up for screening?
Well, unfortunately, lots of our population, lots of our even the educated women, they are not well aware about the importance of pap smear, importance of cervical screening, and I think it's the failure on our part that we are not educating our masses. And I think it's the need of the hour that we should start educating our women whenever they visit us to our gynecological clinics for any even benign problem. We should take a step ahead and we should consult them and persuade them to get a pap smear done.
Dr. Mariam,
Indeed.
should I add something in it?
Yes, sure, Dr. Afzal.
So I agree with Dr. Anam what Dr. Anam said, but apart from that, I think we are lacking in terms of educating our school, college, and university people. I think at the school and college and university level, we should give an education about the screening of breast cancer, about the cervical cancer, about the lung cancer. So at the education level, at the community level, we are lacking in terms of educating our younger population who should know when to go for the physician to screen for the breast, cervical, and for the lung cancer. I think we should focus on educating our younger population at college or universities level to overcome these barriers.
Yes, Dr.
I
Afzal,
agree.
I
Yes.
can't agree more. You were absolutely right, because only a percentage of population would be presenting to our clinics, and we need to focus masses. We need to focus our younger population. Yes, I absolutely agree.
Couldn't agree more. So, with regards to the importance of screening, we'll now move to the investigations that should be done for evaluating a cervical cancer patient. And I would like Dr. Serish to take us through the investigations, please.
Thank you, Mariam, for the kind introduction. And so far, the discussion is being very nice. So let's discuss that what investigations should be done in the cervical cancer patients, and then we'll move to the discussion on that particular case. So cervical cancer, in cervical cancer, we need to get the physical examination first by the physician, and then the biopsy of the cervical lesion is important to determine whether what type of pathology is this. Is this a squamous cell carcinoma, which is present in 95% of the cases, or adenocarcinoma, or adenosquamous carcinoma, or there are other pathologies like the neuroendocrine cancer, which are the rare pathologies, but we need to find out that what type of the pathology is this. Now, after the knowing the pathology, it's important to know the extent of the disease. So to know the extent of the disease, the MRI pelvis with contrast is a gold standard to know the extent of the disease. With that, the examination under anesthesia is also very important in locally advanced cases to know the extent of the disease, and it involves the it involves the proctoscopy and the cystoscopy if the patient presents with a locally advanced disease. And then there is one more thing that we need to see, that what is the status of the distant organs. For that, we need to get the CT scan. Either we need to get the CT scan chest, abdomen, and pelvis, including the neck as well, because in cervical cancer patients, the disease can travel from the para-aortic lymph node to the mediastinal lymph nodes and the supraclavicular lymph nodes. So it's also important to assess the supraclavicular lymph nodes during the examination as well, when the physician is doing the examination. And in addition to that, we need to check it in the scans as well. Now, one more thing I want to add here is because we actually, our patients have the limited resources. So what we actually advise is CT scans for our patients to know the distant sites of the disease. But if there are enlarged lymph nodes in the para-aortic region, so there are two ways to deal with the enlarged nodes in the pelvis or the para-aortic region. So either you get the biopsy of those lesions or you get the PET-CT scan. So to establish the diagnosis. Because if the para-aortic nodes are present, we need to incorporate them into a radiation field. And for this particular case, we would like to get the MRI in case number 1, as it is it's a early stage disease, stage 1B2, because the size is between 2 to 4 centimeter and is just confined to the cervix. So we would like to get the MRI pelvis done and the CT scan chest, abdomen, and neck to know the distant disease.
Thank you, Dr. Sarish. Dr. Abdul, would you like to take us through the staging of the cervical cancer?
So yes, sure. So FIGO recommended the cervical cancer staging, and we divide every cancer into the 4 stages. 4th means distant metastasis, and 1 to 3 means confined to that organ or the regional lymph nodes. So any tumor which is microscopically involved the cervix, which means that we can't see with the naked eye, so it is stage 1. We further divide into 1A and 1A, 1, 2. And any tumor which is greater than 5 millimeter in depth and involving and having a less than 2 centimeter in size, we call it 1B1. When it is 2 to 4 centimeter in size, it is 1B2. So probably in our case, we did the MRI scans and we did the biopsy. So the scan shows that the disease is less than 2 centimeter in size. So in our case, it is, sorry, less than 4 centimeter in size. So it is, in our case, it is 1B2.
So, Dr. Afzal, as you just told us regarding our case staging, can you please take us through the treatment options of the cervical cancer management?
Sure. So the cervical cancer, we broadly divide the treatment into 3 main groups. Like for early stage disease, any tumor which is less than 4 centimeter in size, we call it early stage disease. The way that I remember, so it includes the stage 1A, 1B1, and to the some extent 1B2 if it is less than 4 centimeter size. We call it early stage disease. Any tumor which is beyond the cervix, or if it is more than 4 centimeter in size, we call it locally advanced disease. And the third part is when the tumor has been metastasized to the distant organs or the distant lymph node, we call it metastatic disease. So early stage, locally advanced, and metastatic, these are the 3 broad treatment divisions for the cervical cancer.
So now, as we've seen the FIGO staging and an overview of the management of the cervical cancers, may I please request Dr. Anam to take us through the management of low-risk cervical cancer?
So when we talk about the low-risk cervical cancer, we are talking about the stage, as Dr. Afzal has described, we're talking about the early stage, right? So what we do is first we need to establish a diagnosis, and sometimes our diagnostic measures are also therapeutic. This diagram is actually showing the procedure of the conization. So what we do is that we do, with the help of the knife conization, we take an appropriate, adequate specimen from the entire transformation zone, and it should at least have a 1 millimeter negative margins, right? So what we do is that for the stage 1A1, if that stage has no lymphovascular invasion, then the cone biopsy with negative margins is going to be enough if the patient opts for the fertility sparing option, right? And there are some criteria for fertility sparing that needs to be met, like where we need to have a very careful selection of the patients who want to opt for the fertility sparing option. And these fertility sparing options can be offered to the patients who range from stage 1A1 to stage 1B1. So in case of stage 1A1, as I have described, cone biopsy with negative margins can be enough, or we can opt for a trachelectomy. In case of stage 1A2 to 1B1, if they meet the conservative criteria, that is, they shouldn't have any LVSI, the cone margin should be negative, tumor size less than equal to 2 centimeter, or the depth of incision less than 1 centimeter, and they have negative metastatic workup, we can go for cone biopsy with negative margins with pelvic lymphadenectomy. If the patient wants to go for not a fertility sparing option, then for stage 1A1, we can go for extrafacial hysterectomy. And we can also go for radical trachelectomy in the stages 1A2, 1B1, and in selected cases of 1B2, if the lesion is less than or equal to 2 centimeter. So what we do in radical trachelectomy, that we take out the cervix, we take out some part of the vaginal margins and the supporting ligaments, while leaving the main body of the uterus and the fundus intact. And what we do that we then put a conservative cerclage in place so that the women can have conception in the future. And pelvic lymphadenectomy, it can be performed with or without the sentinel lymph node sampling. And the radical trachelectomy can be done either abdominally, vaginally, or laparoscopically. It depends upon the expertise of the surgeon and the techniques available. So this is a beautiful specimen showing. As we can see that this is the cervix, we can see the growth coming out of the external os, we can see the parametrium, and we can also see the lymph nodes along with it. And this specimen has been excised adequately. So when we talk about the types of the hysterectomy, like if the patient has gone to the stage from 1B2 to 2A1, then for those patients, we do offer radical hysterectomy, right? And the commonest type of the classification system that we use for hysterectomy is modified Corlo-Murrow classification. Type A is the simple extrafacial hysterectomy in that we are going to offer to our stage 1A1 patients who don't want to opt for a fertility conservative option. And for the type, can you please go back to the previous slide? All right, so the type B, modified radical hysterectomy, could be offered to our patients with stage 1A1 and 1A2 who have a positive LVSI, in which what we do is that we take 1 to 2 centimeter of the parametrial tissues, deroofing the ureter. And but the inferior hypogastric nerves, we do spare them. In the full-blown stage 1B2 or 2A1, what we do is a type C1 radical hysterectomy. In type C1 radical hysterectomy, we take 2 to 3 centimeter of the parametrial tissues, and along with that, we do a nerve-sparing surgery. We spare the inferior hypogastric nerve plexus. Type C2 is going to be a more aggressive approach, and that is not a nerve sparing approach, and we usually don't opt for it. And type D means that you sacrifice the entire internal iliac vessels and tributaries. Next, please. As we can see in this slide, there are different types of hysterectomy being shown. That the first figure is showing the total hysterectomy in which the whole uterus has been complete in radical hysterectomy. In the second figure, we can see that the uterus along with the adnexa and the parametria is removed. In the third figure, we can see that there is a partial hysterectomy, which is of course not recommended in cases of the cervical cancer. It can be done in some benign situations. So when we talk about the surgical options for cervical cancer, we always used to talk about how much radical we have to be as surgeons. But recently, this SHAPE trial that has actually compared radical versus simple hysterectomy and pelvic lymph node dissection for early stage lower risk cervical cancer, it has actually implemented the non-inferiority of simple hysterectomy versus radical hysterectomy. So what was that? That they very carefully selected the patients 700 patients from across 13 countries were recruited, and 90% of them were stage 1B1, although they included patients from stage 1A2 to 1B1. And they stratified the patients with low risk as that they were either had squamous cell adenocarcinoma, adenosquamous, or there was less than 1 centimeter stromal invasion. They have less than 50% stromal invasion on MRI, and the maximum diameter of the lesion was less than 2 centimeter, and grade was 1 to 3 or not accessible. So what they did that they randomized it to either 350 patients received simple hysterectomy and 350 received radical hysterectomy. Their primary endpoint was that they followed these patients to have a pelvic recurrence rate at 3 years, and the secondary endpoints were that how much the extra pelvis disease-free survival and overall survival, and the rates of the sentinel lymph node dissection and parametrial involvement. Next, please. So this table shows the baseline characteristics of the patients, and we can see that they were almost the same. In the first column, we can see the median age, and in simple hysterectomy and radical hysterectomy, it was the same, and almost the ECOG status was the same. They used the same diagnostic procedures with lead cone and cervical biopsy. And as I have already said, that approximately 90% of the patients belong to the stage 1B1. And they recruited 3 types of histological patients: squamous, adenocarcinoma, adenosquamous, and all 3 types of grades were included. Next, please. So what they did is that they use all sort of approaches. They opted for abdominal surgeries. They have opted for laparoscopic, robotic, and vaginal hysterectomies. They did do sentinel lymph node mapping, and it is showing that in how much cases it was planned and how much it was successful. And then they assessed the key post-surgical findings. And the last part of the figure shows us that how much of the patients were receiving the adjuvant treatment, and we can see that it was the same in both the cases. It is not statistically significant between the 2 groups. Next, please. So this is very important if we look at this data, that after median follow-up of 4.5 years, the 3-year pelvic recurrence rate, that was their primary outcome, it was not statistically significant between the 2 groups. In simple hysterectomy and radical hysterectomy, and they both had a similar 3-year pelvic recurrence-free survival. And we can see that the 3-year extra pelvic recurrence-free survival and overall survival was the same. So it was comparative between the 2 groups. And this data makes us think that do we have to be less radical, and can we give the benefit to these patients, these carefully selected cohort of patients, and be less radical in our surgeries? Next, please. So we can see that subgroup analysis showed non-inferiority of simple hysterectomy across the evaluated subgroups. And this is very important when we talk about the different type of surgical strategies to our patients. So it also showed that how much radical if we go, the type of the side effects and adverse effects our patients are going to have. So if we do look at these charts, it is showing that those patients who underwent a radical hysterectomy have much more higher incidence of urinary problems. They had much more higher incidence of urinary incontinence, urinary retention. So if you have done a very radical surgery, but now the quality of the life that your patient has is being affected because of these persistent urinary problems, you have to rethink. So this trial makes us think that we need to de-escalate the radicality of our surgeries, especially in these carefully selected early stage cervical cancer patients. So this quality of life and sexual health, we can see that there are some measures that they measure the sexual vaginal functioning, and the pain scale assesses sexual pain. So all of these things are really important when it comes to the post-operative life of the patient, that how much dyspareunia she is experiencing. And it was observed that there was a significant difference between the two groups when it came to their sexual vaginal functioning and sexual pain at 3, 6, and 12-month assessment. And they all favor that we can opt and we should opt for the simple hysterectomy arm to prevent and to protect our patients from the unnecessary outcomes of the radicality of our surgeries.
Thank you, Dr. Anam. So you've told us that for cervical cancer stage 1A1, it's ideal to go with conization with clear margins. And for stage 1A2 and 1B1, if the patient opts for a fertility sparing surgical approach, then again we can go with conization with clear margins. I wanted to ask, if the patient opts for non fertility sparing approaches, what are the criteria, or how do you define that whether the patient should have a trachelectomy instead of a hysterectomy? Can you just elaborate on it, or does this data that you showed us translates into it?
Okay, so what I understand is you were asking me that how do we decide that a cone biopsy with negative margins is enough, and how do we decide that trachelectomy is going to be enough, right?
Yes.
Okay, so I have explained when I was talking about that we have, as per NCCN guidelines, we need to have a conservative surgery criteria. First, we need to have a cone biopsy with negative margins, and on that cone biopsy, there should be no LVSI, the margin should be negative, and the type should be squamous or adenocarcinoma, size of the lesion less than 2 centimeter, and depth less than 1 centimeter. So when we decide that a patient needs a trachelectomy, either if the stage 1A1 has come out to be that that cone biopsy was, with negative margins, the margins actually came out to be positive, right? We did a cone biopsy and now the margins are positive and the patient has stage 1A1, right? So either what are we going to do? She wants to opt for a fertility sparing option. We can do a repeat cone or we can go for trachelectomy. Or in cases of stage 1A2 to 1B1, we can straight away go to a procedure of having a trachelectomy with lymphadenectomy. So on the basis of these stages, we decide that whether a cone biopsy with negative margins is going to be enough or we need to opt for a trachelectomy.
All right. And Dr. Anam, can you comment on the role of sentinel lymph node mapping in these early stage cervical cancer?
Yes, basically when we talk about the stage 1A1, right? So the stage 1A1 has up to 0.5% risk of having a pelvic lymph node involvement, which is very less, right? But in case of stage 1A2, it is up to 5% that pelvic lymph nodes and less than 1% para-aortics could be involved. But when we talk about the stage 1B, up to 16% of pelvic lymph nodes and up to 2% of para-aortics could be involved. So if we are offering fertility sparing options to these patients in early stage disease, we need to assess their pelvic lymph nodes. And NCCN recommends that we should opt for the sentinel lymph node sampling. And it has a very high sensitivity and specificity. And what is the best criteria to do is that you inject indocyanins green at 3 o'clock and 9 o'clock position. And you should opt for a minimally invasive approach, that is laparoscopically, and look for the uptake of the dye. And the first node that takes up the dye is that means that the sentinel lymph node is positive. And then you need to do the site-specific lymphadenectomy over there. And even if the sentinel lymph node is not positive, then you need to follow a specific algorithm that the node is negative, but we are still doing a site-specific lymphadenectomy in any case. So we need to evaluate our lymph nodes if we are opting for a fertility sparing option. Of course, we need to evaluate lymph nodes if we are not opting for a fertility sparing option. But in either case, lymph node assessment is mandatory and it cannot be emphasized less upon.
Message well taken, Dr. Anam. Thank you so much. We'll now be proceeding to the discussion of management of cervical cancer in intermediate risk, and Dr. Serish will be guiding us through.
So proceeding to the discussion about the early stage cancer management, we talked about the role of the surgery, the fertility sparing surgery, and what type of the hysterectomy we can offer to our patients. Let's talk about that, why and who are those patients whom we should offer the adjuvant radiation therapy, either the adjuvant radiation therapy or adjuvant chemoradiation therapy. So, so I'll go to the next slide first, and that's the actually randomized trial. It's an old trial, but it actually set the ground for advising the radiation therapy to all those patients who showed the risk factors for the local recurrence. So it was the trial which was published in Gynae-Oncology journal in 1999, and it was a randomized trial which actually compared the pelvic radiation therapy versus no further treatment in selected patients with a stage 1B carcinoma of the cervix after the radical hysterectomy. So total 277 patients were entered with at least two of the following risk factors. So total 3 risk factors were included. First was more than 1/3 of the stromal invasion of the cervix. The second one was the capillary lymphatic space involvement, and the third is a large clinical tumor diameter. So these were actually the 3 factors which were included in the study, and on the basis of this. And all of those patients have at least two of these risk factors, and the patients were further stratify. Either they received the radiation therapy or they were being just followed up. So the results showed to us that those patients who received the radiation had better local control of the disease as compared to the patients who were only being on the follow-up. So the 2-year recurrence-free rates was 88% versus 79% for radiation versus the no radiation arm. However, by giving the radiation, the patient experienced a lot of grade 3 and the 4 adverse events. In the experimental arm, which was the RT group arm, the patients experienced a 6% of grade 3-4 side effects, which included the hematological toxicity, urological toxicity, or the GI toxicity, versus 2.1 in the non-radiation arm. So I'm going back to the first slide. So that was the paper which was published by the Sedleys et al. And that's why we call this criteria the Sedleys criteria, and it's called the intermediate risk criteria. So the combination of here you can see that there is a combination of the different risk factors. I'm going through one by one all the risk factors. Like for example, if the patient is having the LVSI plus the deep 1/3 cervical stromal invasion and the tumor of any size, even if it is like 2 centimeter, we have to consider adjuvant radiation to the patients, and we are going to give the benefit. Other is the presence of the LVSI plus middle 1/3 stromal invasion and the tumor size is more than 2 centimeter. Third criteria is the presence of the LVSI plus superficial 1/3 stromal invasion and the tumor size is more than 5 centimeters. So here you can see that either the size is bigger or the LVSI is present. So at least 2 factors should be present. When there is no lymphovascular space invasion, but the deep or the middle 1/3 stromal invasion is involved, or the tumor size is more than 4 centimeters. So either of these combinations should be offered radiation therapy in the adjuvant setting, and the patient will get the benefit. Later on, the evidence, we have the evidence from this Cochrane database systemic review. In this meta-analysis, which was published in 2012, actually enforced the the advice for giving radiation to all of the patients who have the high risk feature for the recurrence, which we just discussed in the Sedley's criteria. So they actually compared the adjuvant radiation with no further treatment after hysterectomy in 397 patients with early stage cervical cancer. And those patients who had the adjuvant radiation therapy resulted in the reduction in the risk of the disease progression. However, there was no difference in the risk of the death at 5 years was noted. But this study was underpowered to assess the survival, probably because of the number of the patients and the less event happened. That's the probable reason. More toxicity were seen, grade 3 and grade 4, which included the hematological toxicity and the gastrointestinal toxicity. But nowadays, these were the data from the patients which were being treated on the older radiation technology. Now we have the intensity modulated radiation therapy technique available, and we can spare the organ at risk in a good manner so that patient can tolerate the treatment easily. So in all of those patients who have the highest feature, we should offer the radiation therapy to the patients and treat them with the advanced techniques available you have. Now I'm going to discuss that what are the high risk features which should be offered the chemoradiation therapy. I'm going to the next slide first. So this is the GOG 109 trial, which actually based the evidence of giving chemoradiation therapy with all of those patients who have the high risk early stage cervical cancer. So those patients who have those high risk features like the positive cervical surgical margins, pathologically confirmed involvement of the pelvic lymph nodes, or the microscopic involvement of the parameter. If you don't give the adjuvant treatment, there is about 40% chance of having the recurrence. So it's better to do it's best in the interest of the patients to consider them for the chemoradiation. Now let's discuss the GOG 109 trial. So in GOG 109 trial, what they did, they included the patients in the two arm. One arm is a radiation alone arm, and the other one is a chemoradiation arm. So in the chemoradiation arm, they did 49.3 grade radiation to the pelvis in 29 fractions with cisplatin and 5-FU. However, we don't generally recommend the cisplatin with 5-FU in this setting. We are doing we do the cisplatin with chemoradiation. We do the cisplatin alone with radiation therapy, and it is well tolerated because sometimes it's difficult it's difficult for the patients to tolerate the combination of the cisplatin and 5-FU, and we see the good results in locally advanced patients who were being treated with the cisplatin alone with radiation therapy. So we have the evidence from the treatment of locally advanced cancer patients. So all of those patients who had the early stage diseases who underwent the radical hysterectomy and the pelvic lymphadenectomy and those who have the high risk features were included in the GOG 109 trial, and at 4 years of progression-free survival actually favored the arm where the chemotherapy was added, as well as the overall survival was more in that group with the chemotherapy and was added with the radiation therapy. However, the grade 3 and 4 hematological and the gastrointestinal toxicity were more frequent in the radiation and the chemotherapy arm.
So, Dr. Suresh, I would like to ask here that as you've told us regarding the Sedley's criteria and the criteria for the high risk that we usually call as Peters criteria, right? So we talking about external beam radiation therapy, or are there any indications for including brachytherapy in these scenarios as well?
Yes, it's a very important question. The brachytherapy in cervical cancer, the indication of the brachytherapy is quite different from the indication we see in the endometrial cancers. So in in those patients who have the positive margins, those are the patients who should be considered after surgery with brachytherapy to boost that particular area, and give the highest dose possible to that particular area where the margin is positive. And the patients who have the extensive lymphovascular space invasion, those are also patients who should offer radiation therapy in the form of brachytherapy.
Thank you so much, Dr. Sailesh. So, may I request Dr. Afzal to take us through the management approaches for locally advanced cervical cancer?
So locally advanced cervical cancer has been defined as any tumor which is beyond the cervix, means or for more than 4 centimeter in size is we call locally advanced disease. So when the tumor is beyond the uterus and involve the upper two-thirds of the vagina, we call it a stage 2 disease. And when it is extended beyond the upper two-thirds of the vagina, like it extends to the lateral pelvic walls, or it causes hydronephrosis or hydroureter, or it is involving the lower one-third of the vagina, or it is metastasized to the regional lymph node, we call it a stage 3 disease. When the tumor locally invades the surrounding structures like rectum or the urinary bladder, we call it stage 4A disease. And when it is metastasized to the distant organ, we call it stage 4B disease. So quickly, without wasting the time, I'm going to tell you about the treatment approach for the locally advanced cervical cancer. So as Dr. Sailesh already mentioned, that the landmark trial that was the GOG 109, which is stated or which led the foundation of using or incorporating the chemotherapy along with the radiation for those patients in whom it was initially thought that surgery was done because of the cervical confined disease, but later found that they have a high risk features. So the GOG 109 established that concurrent chemoradiation is superior to the radiation therapy, and uh, and then what agent should be added for with the radiation therapy to to characterize that which agent is best in terms of efficacy, in terms of response. So there was a trial which was conducted by NAJM. The trial was conducted and published in NAJM in 1999. And in this trial, it was in a randomized phase 3 trial in which there were 3 arms. In one arm, the cisplatin was given at the dose of 40 milligram per meter square weekly, which we usually incorporate in our routine setup. And the other 2 arms include the cisplatin 5-FU and hydroxyurea, and the third arm was hydroxyurea. And what they found is that before going to the results, the next slide, please. So the characteristics of the patient, if you look at the baseline characteristics of the patient, you can see that most of the patients have a stage 2B disease. And the characteristics are pretty much well balanced among all the 3 arms. And mostly the patient have 4 centimeter or above disease. Interestingly, if you look at the disease pelvic lymph nodal status, majority of the patient, like 40% of the patients, they were negative for pelvic lymph nodal involvements in scans. Next slide, please. So if we look at the final result of this trial, it shows that the cisplatin arm is more superior as compared to the cis-5-FU hydroxyurea versus hydroxyurea, and the hazard ratio for the cisplatin arm was 0.57. So means it reduces approximately 43% risk of disease progression. So this was a landmark study, and it confirms that by giving a single agent chemotherapy, cisplatin with radiation uh, is as good, is even far good than the combination therapy or single agent hydroxyurea. And if you look at the overall survival curve, it shows the similar. So this trial basically confirms or stamped that the cisplatin will be the agent that should be used for the concurrent chemoradiation in patients with locally advanced disease. Mariam, do you want me to tell about the latest updates that were presented in ESMO, or Dr. Sarish will tell us about the interlace trial which was recently published?
So I'm going to cover the interlace study, and Afzal, you will cover the keynote trial. So recently,
Okay, perfect. Go ahead.
Thank you. So far, recently, we know that the standard of care for the cervical cancer management in locally advanced setting is the concurrent chemoradiation therapy with followed by the brachytherapy. So in November, International Gynae-Oncology meeting, interlace study was discussed, and in this study, it's a very important, and I think probably it's going to be the new standard of care in locally advanced cervical cancer patients. So let's discuss the study design and the results of this paper. So it was an international randomized multi-center phase 3 trial, and as we know that in previously meta-analysis, the overall survival benefit was shown to consider when it was being considered to the short course of chemotherapy before a concurrent chemoradiation therapy. So so in this study, they stratified the patients into two groups, and in one group, the induction chemotherapy was given with the carboplatin and paclitaxel. The weekly chemotherapy was given. And total 6 cycles were given to the patients. Total 6 cycles were planned. Followed by the concurrent chemoradiation therapy. And it was the experimental arm, whereas the standard arm was the concurrent chemoradiation therapy. So in induction chemotherapy, as I've just mentioned, that the paclitaxel and the carboplatin was given, and in chemoradiation setting, the weekly cisplatin was given, and it was aimed to minimum total EQD dose, EQD2 dose of 78 gray to the point A, and the image guided adaptive brachytherapy, 3D image guided brachytherapy was recommended in all the patients. It was recommended that the overall treatment should be completed within 50 days. The primary endpoint of the study was the progression-free survival and the overall survival. Here you can see that it was a multi-center study, but most of the patients were from the United Kingdom. Most of the patients who were included in the study were stage 2B and 3B. Pathology predominantly was a squamous cell carcinoma, and about you can see here that the positive lymph nodes. Many patients were included in this study where they have the positive lymph nodes. Next slide. The adherence to the therapy, the chemotherapy, radiation therapy was very good. And let's talk about the radiation therapy. So the patient received the external beam radiation therapy with IMRT technique or the 3D conformal technique. Most of the patients received the radiation with conformal 3D conformal radiation therapy. And it was aimed in the brachytherapy that the 3D, the high risk CTV D90 dose, which should be 78 gray, was achieved in many patients. Next slide. So here you can see that the progression-free survival and the overall survival actually favored the experimental arm, where the induction chemotherapy was given. And in this slide, you can see that the patients, what was the pattern of the relapse in the interlace study? So the pattern of the relapse was the distant. There were more distant failure in the patients in the standard arm, where the induction chemotherapy was not given. So total distant relapses were 12 in number, whereas 20 they were less in the induction chemotherapy arm. There was less distant relapses as compared to the standard arm.
So I have a question to Dr. Saish and Dr. Afzal both, if you can tell me that what was the side effect profile in patients who underwent induction chemotherapy?
So mostly the side effects, let me go back to that slide. So here you can see that most of the patients had the 6 cycles, which was advised, and those patients who had fewer than 6 cycles had the different kind of side effects, like the hematological side effects and non-hematological side effects. But mainly patients had the hematological side effects.
And were most of the patients able to complete the induction chemo in time?
Yes, here you can see that about 84% of the patients completed chemotherapy, total 6 cycles, whereas 92% of the patient completed 5 cycles of the chemotherapy. So it was a good adherence or the compliance to the chemotherapy.
So, Dr. Afzal and Dr. Sarish, how confident are you guys, or how confident do you guys feel in the implementation of this interlace trial with regards to our practice?
I think let's discuss the Keynote A18 trial, then we will conclude it.
All right. So, Dr. Afzal, will you take us through the Keynote trial?
Sure. So basically, the keynote is in another seminal study that was presented in an international gynecological conference in 2023. And what uh, what led to this trial is that we have seen already that induction chemotherapy improves progression-free survival and overall survival, and it was given for the patients who have a heavy burden disease. So they think that by incorporating the immunotherapy, what changes that one can see after adding an immunotherapy. So Keynote basically A18 is in a randomized phase 3 trial in which they added the pembrolizumab, which is an immunotherapy, to the concurrent chemoradiation. In one arm, patient received chemotherapy, concurrent chemoradiation. And in another arm, patient received pembrolizumab 200 milligram every 3 weekly, followed with chemoradiation, followed by uh, maintenance pembrolizumab. So if you look at the baseline characteristics of this trial, next slide, please. So if you look at the baseline characteristics of this trial, most of the patients were stage 2 and above disease. So means in this trial, high-risk disease patients were included, means they are node positive disease. So either they have a pelvic or para-aortic lymph node involvement, they were included. And the stage 3 and a stage 4. So the experimental arm was given a pembrolizumab 200 milligram every 3 weekly with concurrent chemoradiation, followed by 400 milligram of pembrolizumab every 6 weekly as a maintenance up to 15 cycle. And if you look at the next slide, please. And if you look at the overall survival and progression-free survival, you can appreciate that the graphs are pretty much well separated in terms of PFS at 24 months. So in approximately 50% of the patients that were included in Keynote 1.8 trial were white, and 30% of them were Asians. So they comprise of a mixed population. And if we look at the results, so the 24-month progression-free survival was 67.8 months in the arm containing pembrolizumab versus 57.3 months, 3% in the arm that is receiving placebo, with hazard ratio of 0.70, means significant 30% reduction in the risk of disease progression. And if we look at the subgroup analysis, we saw that by adding the pembrolizumab, the benefit was seen in all the subgroups, whether they are node positive, whether they have a locally advanced disease, in all the subgroups, whether they are Asians, white, black. So this trial shows that by adding the pembrolizumab to the concurrent chemoradiation, the progression-free survival improves uh, uh, by good 30%. And if you look at the overall survival data, so it is too early to say for the overall survival, but the graphs are still separated at 18 months. So we are hoping in future for overall survival data to get matured and to get analyzed and get interpreted and to be used in the guidelines and in the future practice. So this is basically the same what I already mentioned you, or I already told you that PFS was consistently seen better in the pembrolizumab arm as compared to the concurrent chemoradiation arm in all subgroups, like patients who have less than 65 or those who are greater than 65, those receive non-IMRT technique versus IMRT technique. In every population, the pembrolizumab provides a benefit. So next slide, please. Treatment-related adverse event, the most common adverse event that we see with concurrent chemoradiation or with the addition of pembrolizumab was anemia. And if you see, it is most likely because of the concurrent chemoradiation, not because of the immunotherapy. Apart from anemia, nausea, diarrhea, low counts were the most frequent side effect that we noticed. And if you compare the numbers, they are pretty much the same. So there was no added toxicity was seen by adding the pembrolizumab to the concurrent chemoradiation group. Next slide.
So
Okay,
I have a
so
before
yeah,
concluding,
sure.
Afzal, I have a question that how in our setting, how much in our setting does it cost for one cycle of pembrolizumab?
So, Dr. Sarish, as you know that pembrolizumab is not a registered drug in Pakistan, so the cost varies, and the issue is of its maintenance, like it's maintaining on a cold chain. So we don't know how the pembrolizumab being imported in our country, whether through the gray channel, whether through the proper shipping channel, we don't know. Roughly, it cost varies because there was no standardized or registered drug, so there was no standardized price. Roughly, cost varies from 1.5 lakh to 3 lakh per dose, and this should be given every 3 weeks during the chemo radiation therapy, followed by maintenance as well for 15 cycles.
All right. So it gonna cost a lot to the patient if we think that as the results are promising from the
Yeah.
Keynote 18 trial, but it will cost a lot to the patients.
Yeah, certainly. And we already know that the cervical cancer is the cancer of our developing countries or the low socioeconomic status countries. So this added cost, apart from the general treatment, yes, it will be discussed. It should be discussed with the patient in detail uh, before starting it.
So I think the results, the 5-year results of the Interlace study are promising because our patients and in our setting the patients easily tolerate this regime of carboplatin and paclitaxel. What do you think about it? What's your experience?
So I haven't, Dr. Sarish, started my patients on induction chemotherapy. Yeah, but in general, when we give carboplatin and Taxol in a weekly doses, like in esophageal cancers, or like in patients who are being treated for different cancers with curative or metastatic setting, the tolerance to the carbotaxol was pretty much good. And by incorporating this induction chemotherapy to the patients of the cervical cancer, followed by the CCRT, I think its tolerability and its cost would be more appropriate than the immunotherapy or the any other fancy drug.
Exactly, completely agree with you. So I think the results are promising, and it seems like going to be the new standard of care, the induction chemotherapy, because there are less distant metastasis when you give the induction chemotherapy. Similarly, we also see the results of induction chemotherapy in the rectal cancer, locally advanced rectal cancer studies, that if you do
Yeah.
the induction chemotherapy, there are less number of the distant metastases.
Yeah, agree.
Thank you, Dr. Sarvesh and Dr. Afzal. So I'd like to thank all of my speakers for coming today on our platform and discussing this important topic. So, to conclude, I would just say that treatment of carcinoma cervix should be centralized in specialized centers who have a multidisciplinary approach for treatment of such important cancers. And it should be based on comprehensive and precise knowledge of prognostic and predictive factors for oncological outcomes, the side effects, and quality of life of the patient. So, with this, we'll conclude our session and we'll be up with some other topics as well in recent future. Thank you for joining. Thank you so much.